Hello, I'm Clarke-Pearson from Chapel Hill, North Carolina, and I'm happy to participate in the Globe-athon to end women's cancers. Today I'm going to talk about venous thromboembolic complications, which are serious complications following gynecologic surgery. First of all, I think I need to define for you or explain what a venous thromboembolic complication is. There are two forms. One is a deep vein thrombosis, which is a clot that forms in the leg or in the pelvis. And if that clot were to break loose and go up the vena cava and into the heart and into the lungs, it's called a pulmonary embolus. Pulmonary embolism can be fatal, and therefore we would like to prevent them if at all possible. The next question is, who's at risk to develop pulmonary embolism and venous thromboembolic complications? There are a number of well-known risk factors that are important for you to recognize and to bring to the attention of your doctor as you prepare for surgery. The most important risk factor is a patient or a woman who's had a prior venous thromboembolic event. She is very likely to have another event at a subsequent surgical procedure. Cancer is another very high risk factor, and so of course we're talking about ending women's cancers, but at this point in time in the treatment of cancer we are dealing with a higher risk patient population. Age is an important risk factor, and it seems that at age 40 and beyond becomes a higher and higher risk factor. At age 60, it's about 50% more than it is at age 40. Major surgery is, of course, a very high-risk operation, and the longer the surgical procedure or the more blood loss, the higher risk the patient has of developing a deep vein thrombosis or a pulmonary embolism. Obesity, which is becoming a bigger and bigger problem worldwide, is also a risk factor that must be taken into consideration despite the fact that the patient's otherwise healthy. Hormones also increase the risk of a venous thromboembolic event. By hormones I mean either oral contraceptive use at the time of surgery, hormone replacement therapy in menopausal women, or the use of a drug called tamoxifen, which is commonly used as maintenance therapy for women with breast cancer. All of those hormones do increase the risk of blood clotting and leading to these complications. Pregnant patients, especially near the end of their pregnancy and in the first 6 weeks after they've had a baby, are at higher risk to develop a venous thromboembolic complication, even though they may be very young. And then finally there's what are called thrombophilias, which are inherited clotting disorders that increase the risk of thromboembolic complications. How would you know if you have an inherited clotting disorder? It would be based on your family history more than anything else. So if you had other family members that had venous thromboembolic complications, you should discuss that with your physician, and he or she may want to do some additional testing. Well, knowing who is at risk, is there some way we can reduce that patient's risk? And the answer is yes. There are a number of approaches where we can use prophylaxis or preventative measures to reduce the risk of deep vein thrombosis or pulmonary embolism. There are two main approaches. One is to reduce stasis in the legs. So slow blood flow through the legs increases the risk of blood clotting. The other approach is to use drugs that thin the blood so it doesn't clot as easily. So first of all, with regard to reducing stasis, we like to encourage patients to ambulate as quickly after surgery as possible. In other words, getting up out of bed and walking. Walking makes the muscles in the legs contract, and when those muscles contract, it squeezes the veins and keeps the blood flowing. There are other devices and approaches to also reducing stasis. One is to use graded compression stockings that can be put on the legs either up to the calf or all the way up to the thigh. They must be fitted properly, because if they are too tight, they can cause a tourniquet and actually slow down blood flow. But fitted properly, we know that the graded compression stockings will squeeze the superficial veins, driving the blood into the deep veins and increasing flow in those deep veins. A slightly better approach to reducing stasis is using sequential compression devices or intermittent pneumatic compression. These are sleeves that are put around the calf or the whole leg, which inflate for about 10 seconds every minute, squeezing the leg and therefore pumping blood out of the leg back to the heart and reducing stasis. So all of these approaches are approaches that we take here. Using anticoagulants is another approach, and the two anticoagulants that are commonly used are what are called low-dose heparin, which is a blood thinner that's given by an injection either 2 or 3 times a day, as long as the patient is in the hospital after surgery. And in cancer patients, we find that it's beneficial to continue that for a month, even as an outpatient. The alternative drug would be to use a low molecular weight heparin, of which there are several different types, which is given once a day. And again, if the patient has cancer and after surgery, we would usually continue that for another 28 days after surgery. So those two approaches are our most effective ways of reducing the incidence of venous thromboembolic complications, probably by about 70%. Now, you can also combine the two, so we could use compression on the leg and a low dose or low molecular weight heparin at the same time, attacking the risk factors by two approaches, and we oftentimes do this in very high risk patients. Well, sometimes we can't prevent deep vein thrombosis or pulmonary embolism, and in those situations it's important to make the diagnosis as quickly as possible. So what signs and symptoms would I be looking for as a physician seeing my patients postoperatively? The first thing with regard to examining the patient would be to look at her legs to see whether she has any swelling, any pain, any redness, or increased pattern of her veins on her legs. Those findings would be very suggestive of a deep vein thrombosis. I would confirm that diagnosis by using ultrasound to scan the patient's veins to see whether I can identify a clot or whether we see decreased blood flow through that vein. And then a pulmonary embolus, which is of course the most serious complication, might be recognized by a patient who has shortness of breath or chest pain, maybe a cough, or she may even cough up blood, or just on monitoring her oxygen levels in her blood may notice that it's fallen down. So those would be potential signs and symptoms of a pulmonary embolus, and the proper approach to making that diagnosis would usually be to do a spiral CT scan of the chest or a lung scan to identify whether the patient does or doesn't have a blood clot gone to her lungs or a pulmonary embolus. Finally, once I recognize that the patient has a deep vein thrombosis or pulmonary embolus, it's imperative to treat her as soon as possible. The longer we wait before we can start the patient on treatment, the higher chance she has of dying of this pulmonary embolus. The approach to treatment is to use blood thinners, anticoagulants that thin the blood to stop the clot from getting bigger, either in the leg or in the lung. Usually we immediately start using heparin given intravenously rather than as an injection, and then continue that dose of heparin continuously for up to 5 to 7 days. At the same time, we start the patient on an oral blood thinner called warfarin or Coumadin that can be taken once daily. And we will continue the warfarin, stopping the heparin, but continue the warfarin for somewhere between 3 to 6 months after we make the diagnosis of deep vein thrombosis or a pulmonary embolus. Well, I appreciate your attention to this little mini lecture and hope it has been informative. Thank you.